When we assess patients we're trying to consider whether to use anti-VEGF, one thing we do consider is their ability to come back and see us. Will they be compliant with coming back to see us monthly in order to receive these injections? There are some patients that the thought of getting an eye injection is overwhelming and they can't handle it and they prefer to have laser treatment. So we have a frank discussion about the risk and benefits of each of the different treatments, and some patients do opt to have laser treatment, particularly for proliferative diabetic retinopathy. It's effective, it's a standard treatment for decades, and it does work in reducing their risk of vision loss. Other patients, the thought of laser is anathema to them. They don't want a bright light in their eye, and they've heard of friends not seeing well peripherally, and they felt like the laser harmed their eye, and they're more open to having injections. So it really depends on the particular patient. And then there's issues of whether the patient can get there monthly. Some patients have already missed too much work, and they prefer the idea of just having laser and being done with it. So it really depends. We're big into tailoring treatment decisions based upon the patient's particular needs. Thankfully, we have different treatment options available to patients that can be tailored to their particular needs.
Complications associated with panretinal photocoagulation may include loss of your peripheral vision, problems with your nighttime vision, pain with the procedure, or sometimes blurring in the center when macular edema occurs. Complications with vitrectomy surgery for diabetic retinopathy are rare, but they do include infection, bleeding, and a risk of retinal tears or retinal detachments. If a patient has not had cataract surgery, vitrectomy surgery can promote a cataract to form faster. Complications that can occur with focal or grid laser targeted towards the macula are rare. Over time, patients can develop a scotoma, which is a small blind spot in areas of previously treated retina. However, this treatment modality is very well tolerated. Complications associated with intravitreal injections with anti-VEG F therapies are typically associated with the injection procedure. These may include discomfort at the injection site, bleeding in the conjunctiva, as well as mild pain. There can also be some burning or irritation after the procedure, and that is typically due to the sterilization techniques we use. Most of the time, these complications resolve in the first 24 to 48 hours. The more serious side effects with intravitreal injections are quite rare. These may include infection, retinal tears, or retinal detachment, and we estimate that these occur about once every 1 in 3,000 to 1 in 1,000. There are more serious side effects that can occur, such as cardiovascular and thromboembolic events. In patients with diabetes receiving anti-VEG F therapy, clinical trials show that these may occur anywhere between 5 and 15% of the time in patients that were studied in a 2- and 5-year clinical trial. Physicians should be aware of these side effects when starting patients on these therapies. There are other complications associated with intravitreal injections with patients that are getting corticosteroids. Steroids can lead to an elevation of the intraocular pressure, as well as promotion of a cataract to form. Physicians should be aware of these side effects and monitor closely. Because the treatments have been shown to be extraordinarily beneficial to our patients, there are very few barriers to therapy. For surgery, patients may have systemic comorbidities such as heart disease or kidney disease, which will prevent us from operating on them because they may not be able to tolerate anesthesia. With intravitreal injections, I find that psychological factors may be the biggest barrier. Most patients don't like to have anything done with their eye, and just having the thought of a needle injection frightens them. But we get around that by saying that it's a virtually painless procedure, and most patients do very, very well. Some of these intravitreal injections are quite costly, and there may be a financial barrier. From a provider perspective, carrying stock of these high-cost medications can create a problem with cash flow if there is a threat of non-reimbursement or delayed payments.
So sometimes managed care does impose what's called step therapy on physicians, in which they're asked to use lower-cost alternatives to treating diabetic macular edema or proliferative diabetic retinopathy. Studies have shown there are 3 main classes of anti-VEGF treatments. 2 of them are labeled drugs, meaning they've gone through the FDA process of approval, and one of them is not. It's a non-FDA approved drug for the use, for ocular use. But studies have shown when you compare these three drugs, in many situations they're equivocal, they work equivalently. So we're open to trying the less costly drugs first, but sometimes they don't work as well as the other two labeled drugs. Studies shown, one called the DRCR Protocol T study, actually showed that patients with diabetic macular edema and vision of 20/50 or worse do better using labeled drugs, particularly one called aflibercept, than those using the other two drugs. So there are specific indications to use certain labeled drugs versus other drugs, but most retina specialists are aware of the differences in cost and try to weigh that in medical decision making. But there are certainly indications where it's better to use the labeled drugs because of their formulations, because there are some other studies that do show they work better in particular situations.